Studies have shown, volunteer studies, the most common test anesthesiologists use is the 5-second head lift. But at a train to 4 ratio as low as 0.5, 11 of 12 volunteers were able to maintain a 5-second head lift. And again, even with when we see absence of fade, clinicians are unable to really detect fade unless train to 4 ratios are as low as 0.4 or lower. So most of the time when you see 4 strong twitches, a significant percentage of those patients can still have residual block. We did a study where we looked at using all these tests, head lift, hand grift, absence of fade, and then at the time clinicians were ready to extubate the patients, they called us in the room. We looked, had the patient recovered neuromuscular function. We found that 88% of these patients had not achieved a train to 4 ratio of 0.9 or greater. So despite using these tests, a significant percentage of our patients still have not recovered train to 4 ratios of 0.9 or greater at the time we're ready to extubate the patients at the end of the case.
And that's another good point to emphasize here. In the beginning of this program, we spoke about the different depths of neuromuscular blockade, and our qualitative monitors are very good, actually, at being able to measure deep neuromuscular block with a PTC count, moderate level block with 1, 2, or 3 twitches. But once we have 4 twitches, that shallow level of block, these fail to adequately measure shallow level of block. Again, towards the end of the case, it leaves us in a conundrum here where our monitor isn't good for assessing lower level, the shallow level of block, and our clinical tests are unreliable.